And hello to you, and welcome to the Richard Nichols Podcast, the personal development podcast series that's here to help inspire, educate, and motivate you to be the best you can be. I'm psychotherapist Richard Nichols, and today's is a bonus episode. It's an interview with Matt Elswood. And if you're ready, we'll start the show. Hey, pod peeps. It's the middle of the month already, and although I wasn't planning on recording any new episodes with guests, that was just going to be a lockdown 2020 thing, but so many have been in touch to say how you've enjoyed having something different to listen to for a change on my series, so I thought I'd do a few more, and when Matt reached out to me to ask if I'd like him to come on to the show and talk about the medication side of mental health to help with our understanding of antidepressants and antipsychotics and so on, I thought it was too important a topic to ignore. And as it's somebody that I already knew and trusted with no agenda or anything, I thought, all right, well, let's do one for the new year. So we did. And we recorded it just before Christmas. In it, we talk about psychosis, the placebo effect, and the psychology of being someone starting to take medication, as well as the pathways within the NHS to get the ball rolling as well. It was a really interesting conversation. Matt is a mental health pharmacist, a Chief Pharmacist, no less, in Nottinghamshire Healthcare Trust. He was made an honorary associate professor at the University of Nottingham and is a top bloke. Have a listen, and you may be surprised at what you learn. Catch you later. Hello, Matt. How are you today?
I'm good, thanks, Richard. How are you?
Brilliant. We're recording this just before Christmas of 2020, and I know this podcast is going to be released in January next year. 2021 feels quite hopeful. It feels like there's something good brewing in the future for us, that we're over the hump now. It's freewheeling downhill all the way. Whee! Is there some truth in that?
I don't know. I really hope so. I've just been writing everyone's Christmas cards and gifts for work colleagues, and I've reflected on how grateful I've been for everything that they've done this year. And I've probably remarked in everyone's card that actually here's hoping for a different kind of 2021. So I share your hope.
Well, I'm an optimist, but I'm also a realist. I'm aware that, we're probably halfway through all the hassle that we've had, and things will probably get better, but I'm aware that it means a lot of stuff has got to be done, and we might still have to lock down multiple times and wear masks and wash our hands and keep ourselves distance from everybody for a lot longer. And it's doable. We can do this. If we're halfway through it, well, we know that we can do it. So we just got to do it for a little bit longer, just be a bit more patient. So, Matt, you are, on paper, your term would be a pharmacist.
Absolutely.
There's a lot more to you than just I am a pharmacist, because that does sound like you work in boots.
Yes, and there are different types of pharmacists. We're a broad church. So personally, I'm a specialist mental health pharmacist. I've worked in a range of different mental health settings now for nearly 15 years, including all types of inpatient and community-based mental health services and forensic mental health services too. It's my chosen area of specialty. And I also do a bit of prescribing, so I've trained to do that. I work in a community mental health team in South Nottinghamshire. I run my own clinics, I see patients. And I don't say that to identify myself as somehow special or unique. This is something that lots of pharmacists are doing around the country, and we're growing in number. So in Nottinghamshire, we're currently 2. This time next year, I anticipate we'll be 4. And I think it's a similar picture around the UK. It's a role that's expanding.
Excellent. So you know a lot more than the general public ever would, probably, about psychiatric medications, the different types, the different companies that make and produce and sell stuff. Do you work with the GPs?
Yep, absolutely. I work with GPs, with colleagues in the mental health team, so psychiatrists, community psychiatric nurses, psychology, psychotherapy, occupational therapy, a full range of professionals, and we all play our part, I think, in trying to help out people that we work with.
Do all of those people have different attitudes, ideas, agendas?
Absolutely. And a big part of the role for me is holding a space to hear all of the different voices about medication and kind of weaving all those voices together so that we adopt a coherent approach that reflects the individual person's needs, what we know from the research, and that kind of thing. That's a big part of my role, bringing different people together around medicines.
I guess there's a terminology. We use the term medication. And people just in the public might just use the word pills, but that can vary from anything from taking Nytol to lithium, and everything that's in between, and maybe all the stuff that's even bigger, if we use that word, than lithium. But what are, as far as the layman public would try to understand, what are psychiatric medications? What do they do? How do they even work?
Yeah, great question. So there are a range of different types of medicines. You've got antidepressants, antipsychotics, medicines that used to be called mood stabilizers, and now we call them anti-manic drugs or anti-manic agents. There are other medicines too, like sleeping tablets, benzodiazepines that help people to stay calm. And they all work in slightly different ways, but essentially they all work by altering levels of different transmitters in the brain that have different roles. That's how they all work. And people achieve that actually through other means too, other than taking medication.
Through diet, or?
Yeah, so foods, through illicit substances, through medicines that you can buy over the counter, or in Holland and Barrett and a range of different places. Other shops are available.
Yeah, I've heard people talk about something as simple as St. John's wort.
Absolutely. So that's a herbal medicine that some people have taken and found to be effective for depression, although it's not currently recommended. I've got, I suppose, a way of looking at this, because lots of people do talk to me about St. John's wort, other medicines, multivitamins, supplements. I suppose my approach to this is there's what the evidence base says, there's what the literature says, and then there's what individual people experience in their own body when they use things, when they take things. And I respect that people will take a medicine or a supplement and they'll derive the benefit from it that they get.
Absolutely.
And it's not for me to poo-poo that, actually. It's about respecting that, and as long as it's safe with respect to anything else that they need to have, then I'm open to that.
There's definitely a placebo effect to everything that we've made our minds up is going to help us. But there's also the nocebo effect. There's a negative side of things, that if we don't think that something is going to help us, then it won't. So easily, so well. And that's frustrating. We see it even in surgery, where if somebody goes into a surgical procedure telling themselves this isn't going to help me, then it doesn't help, and the surgeons are scratching their head going, what? But I've done something for real. This is genuine here. Can we find even that with things like antidepressants at all?
Absolutely. In fact, there's a well-known phenomenon whereby people who take placebo in antidepressant trials respond comparatively quite well to the placebo. So what you might imagine, you would think it would make no difference. But actually, people do respond and do well with the placebo. People tend to do better with the antidepressants, which is how we know that they work for some. But that placebo effect and the effect of being in a clinical trial as well. And sometimes that means blood tests, procedures, contact with other people, professionals, all of those things, I think, amount to having some small therapeutic effect for people.
And possibly without any negative side effects that can sometimes come with some medication. A lot of people just don't fully understand about psychiatric medication, what it can do, the benefits of it, and maybe when it's not the right thing, or maybe when it's almost always the right thing, but they have other side effects, maybe stomach ache or something like that, and think, oh no, this is a problem. I must come off this medication. Are there some negative side effects to some medications then?
Absolutely. And, this is something I encounter on a day-to-day basis. So antidepressants are generally thought to not to have particularly troublesome side effects, but most people do experience some difficulties and side effects with those. Side effects of things like lithium or valproate that are used as mood stabilizers. They have side effects, different types of side effects. People that take antipsychotics can report a range of side effects. One of the interesting things is we're trying to get better as an NHS at asking people about side effects and helping them to identify side effects. Some people don't even realize they have side effects until you ask them, have you ever experienced this? And you identify it. And then that opens up the opportunity for a conversation about what we could do about that, or what you could do about that. Because I think another thing about me is my ethos is the last thing I want to do is to give people tablets for side effects of other tablets, really. What I want to do is help people to find a way that they can manage side effects without more medicines through practical things, or through making small changes that they can make. If that's possible, I think that's always a really good place to start.
So what's the difference then between an antidepressant and an SSRI? Are they the same thing?
Yeah, so there are a range of different types of antidepressants. SSRI is one group, and that's a group of antidepressants that boost levels of serotonin in the brain, and other parts of the body too, but that's how they work. There are other antidepressants that boost serotonin and noradrenaline, another transmitter. That might be helpful for some people with a depression that doesn't respond to just serotonin boosting. And then there are other new, more novel antidepressants that affect a range of different transmitters, probably, far too many different transmitters. And, we're reaching the point now where we're seeing things like S-ketamine, a derivative of ketamine, coming into use, which is completely different from traditional antidepressants.
So does that mean that nobody really knows which one is the one that's going to help them until they take lots of different ones?
It's often the case. From the studies, around 2/3 of people will do well with the first antidepressant that they try. And around 1/3 of people will then try a different one, and around 2/3 of them will respond. So it's that kind of rule of 2/3. So the more antidepressants you try, the more likely you are to come across the one that really helps your depression. But that being said, there's another really important question around whether your type of depression is best treated with antidepressants or with different approaches. Because one reason that people can try 10 antidepressants without success is maybe that they have a type of depression or a mental health condition that doesn't need antidepressant treatment, or for which antidepressant treatment perhaps isn't the ideal.
Yeah, I used the phrase reactive depression and clinical depression with my clients to help them understand that maybe there is a genetic disposition, that it's clinical, that we have to accept that, but then sometimes the reason somebody's depressed isn't because there's a natural genetic problem, that it's their life, and often people know that. They come to therapy to say, yeah, I've gone through this bereavement process, or I've lost my job, or I'm in a terrible relationship, or I've been abused, or I'm having all these problems. Does that mean that sometimes those patients don't benefit too much from antidepressants at all?
Yeah, I think it's one of the areas where a lot of skill is needed to try and identify who will do best with antidepressants and who won't. So the studies suggest that people with moderate or severe depression will do better with antidepressants, or rather that the benefits for them are likely to outweigh the negatives, because all medicines have negatives that come with positives. Whereas if you've got a mild to moderate depression, then the benefits are not as striking. So the negatives will probably outweigh the benefits. So that's one way of looking at it. At the same time, I think it's important to be open-minded. And if someone's got a mild kind of depression, but they found an antidepressant, an SSRI, life-changing, then it would be ridiculous to deprive them of something that really improves their life, just based on studies.
Yeah, I've certainly had clients who they'll come in for therapy, for talk therapy, because they know that the reason they're unwell and not feeling right is because of their experiences. But they find it so hard, they're so emotional that they can't talk
Yeah.
unless something brings them down a little so that they can face the issue. And we spot it with people. We spot whether they've been drinking before they come in, whether they've been drinking alcohol, and obviously that spoils their therapy a bit. They think that it's helping them because, hey, I can be a bit calmer now. I can talk to this therapist, but it's not good to come into therapy drunk. It's not good at all.
Yeah.
And that's very different to having some sort of mood stabilizer or something else that's going on in their bloodstream. Antidepressants and alcohol are two very, very different things, I assume. Do you think the public associate the two, that putting anything in their body is wrong?
Yeah, and I think there's an interesting question there around the difference between alcohol and illicit substances and medicines. And often I think what you're describing with people using alcohol before therapy, it's about perhaps making them feel more confident to speak, or it might be about slightly suppressing how emotional they feel so that they can feel in control in the consultation. One of the roles, I think, of medication sometimes people have to wait a long time before they can get the therapy that they need or the talking therapy that they need. And sometimes an antidepressant can help in that interim period. Sometimes people are not in a position whereby they can start to engage in talking therapies. So we need to use an antidepressant to get them to a point at which they can do that work. Because talking therapies can be obviously very challenging, or only too well how difficult it can be for some people to have to talk about some of the issues they need to talk about. And therefore medication sometimes has a role in getting people ready for that work. For some people, it's a combination of talking therapies and medication that will be needed to help them. So that's certainly the case in some anxiety disorders. So generalized anxiety disorder when it's quite severe, obsessive compulsive disorder when it's quite severe. That the evidence suggests an antidepressant and talking therapy is the best way forwards, and some forms of depression also. And you mentioned reactive depression and clinical depression. Obviously, they can overlap sometimes, which is where you need skill to decide what's happening. And reactive depression, I think, I'd always like to see someone try and work through that with talking therapies if it's possible, if that's appropriate with the level of risk. Just because I think that I have this thing in my mind that if someone's gone through difficult life experiences, losses, bereavements, episodes of abuse, I think in a way it almost gives the wrong message to say that a medication is going to take that away or sort that out. I think actually it's about going through the talking therapies and working through those issues to have perhaps a more of a lasting resolution of those difficulties, rather than taking a tablet and the tablet will do it for us, which often we find just isn't the case anyway.
Well, I guess that's why in talk therapy it's described as a complementary therapy. It complements medicine. It's complementary medicine, as opposed to alternative medicine. I guess the Holland and Barrett and other suppliers are available. Those sort of natural herbal stuff, that would be alternative therapy, whereas talking therapy is a complementary therapy because it complements the medication. Now, when somebody's only got 10 minutes with a GP, though, how can a GP manage to figure out what's the right thing to do?
Absolutely. I think that's a real challenge for GPs. And, they're generalists, so they have to know about a wide range of different conditions. So they might have a specialty, but they're probably never going to know about each individual condition that they're going to be confronted with on a day-to-day basis. They're not going to have a deep, detailed knowledge of each condition. So it's about what we can do to help GPs to make the right decisions early. So how do we give them information, support? How do we make it easy for them to refer onwards when that's the right thing to do? I think that's a real challenge. And actually, one of the things that I've experienced with patients sometimes, and people that I see come in, you have an appointment, and actually they might talk for 6, 7, 8, 9 minutes about a range of different things that they're experiencing. And then right at the end, they might say, oh, and by the way, I've been feeling really dreadful and really miserable. And I think if you're a GP, that could be a real challenge in the consultation, because that's the point at which you really want to start to ask some more questions.
Yeah.
So I think, one of the things that people can do is to be really clear about what the most important things are that they want to talk to their doctor about. If it really is about a mental health problem, then be ready to have that conversation first, so that the GP can have a really good consultation with you, help you work out what's the best thing to do, what's going on, what's causing the situation, and construct a plan.
Yeah, if somebody goes to their GP and says, I've been feeling really tired lately, it's likely the GP is going to start looking at other things. Let's have a look at diabetes. Let's have a look at their thyroid. Let's look at all of these things because they're feeling tired lately. But if they come in and sit down and say, I've been feeling so tired with life lately,
yeah,
then the GP knows, okay, this is where we're going in these 10 minutes that we've got. Let's get this sorted. Let's help this person. And they can swivel the chair and look them in the eyes and go, okay, what's going on? What brings you here today? Rather than let's just stare at my computer and work and just be a computer themselves that's got a list in their mind of symptoms and another list of diagnoses and procedures, and go, I've got to match up this patient with something. They can see, oh, okay, I can see what's going on in this person now. But it takes the patient to have the confidence to sit in front of a complete stranger and admit, I'm not right today, and I've not been right for a long time. So frustrating that depression can often strip us of the ability to do that.
Absolutely.
And I hope that people listening who feel that they're in that sort of position can feel the nudge today to go and make that happen. And if they then get prescribed some medication to get things going, would it be the GP that does that, or does the GP refer on to a psychiatrist?
Okay, so in most cases, the GP can start medicines. Different areas of the country have different views on medicines that should be prescribed by specialists. So there are some medicines that mostly are in most places around the country would be started by a specialist, and then the GP can continue them. There are some medicines that are always prescribed by specialists, sometimes for historical reasons, often for safety reasons. So one of the groups of people that I work with are people who are on specialist-only medicines. It means that they have to continue to come and see us in the community mental health team, but they're otherwise doing really well. So actually they see me, and my job is to do a really good quality review of the health, including the medication within that. For me, it's a holistic review. So it's about how they're getting on, how are they living, what about their physical health, as well as their mental health and their medication.
Once they start taking medication, how long does it take before they start noticing some positive improvements in the way they think and feel?
That's a really good question. And it varies from condition to condition. So in depression, what we'll often tell people is that you need to take the antidepressant for probably 4 to 6 weeks to see its full effects. Some people will experience a kind of burst of energy right at the beginning, which can make them feel on edge or restless. Their body all of a sudden can feel activated, but often their mind is still, in the doldrums, in the pits of despair. So actually you've got someone then who's got a lot of extra energy and motivation, but still feels really miserable, which is quite a difficult situation, and it needs to be monitored. Often it takes 2 to 4 weeks for an antidepressant to work and really improve mood. With antipsychotics, again, it's similar. We're often looking to evaluate an antipsychotic over 6 weeks. Sometimes people do notice changes quite quickly. So particularly with antipsychotics that are sedatives, that calming effect, that side effect to begin with of that sedation can make people feel a bit calmer. And sometimes that in itself might reduce the frequency of voices or visions or psychotic experiences. It can reduce the intensity of those. So different medicines have different time courses. Yeah,
there's been a stigma about taking medication for a lot of people. There are some that are because of their culture, because of their upbringing, because of their attitudes in the society. They're very welcoming of assistance, of help, and they think of the brain as like a computer. It's got a virus. It needs reprogramming. This pill will help. And then there are others that will associate antidepressants with something like cocaine and heroin and think, well, I know that people who take heroin just keep on taking more and more and more because their body creates or their brain creates a tolerance to it. And just to feel normal, they've got to have an enormous amount, let alone to feel high. Do we find that there's any similarities with psychiatric medication as well, or is it completely different?
Yeah, so this is a really common question that I get met with. Will I become addicted to the medication that I'm given? And I think the answer is no, not in the same way that people view addiction or dependence in that sense. So whatever medicine you take, whether it's an antidepressant or an antipsychotic or even a blood pressure tablet, you take the medication, it's going to exert its effect on the body. Your body, because it's really clever, it's going to try and restore a normality. There's this homeostasis thing. So whatever chemical you take, whatever medicine you take, your body is going to try and rebalance things. The medicines work by being able to overcome to some extent that rebalancing that the body tries to do, and they exert their therapeutic action that way. And yes, it's true that when some people stop antidepressants or when they stop other medicines, they experience some difficulties, particularly if they stop their medicine abruptly. And that's just the body, again, adjusting to being without that medicine. It's got used to it being there. It's made some adjustments. If you all of a sudden take that away, your brain or your body is going to try and rebalance things again. So a lot of what people experience is that chemical readjustment that's happening.
I wonder if you can put people's mind at rest a little bit that even people who drink a lot of coffee will have the same sort of effect. If somebody drinks strong coffee 3 or 4 times a day and then they switch to decaf, they're going to feel odd.
Oh, absolutely.
Their body has got so used to having caffeine in the bloodstream that they're going to have these crazy headaches and go, oh my God, I'm addicted to the coffee.
I personally experienced this, absolutely. So I drink a lot of coffee, and every year, because I've got a lot of friends who observe Ramadan every year, I observe it too. And that's a month where my caffeine intake dramatically reduces. And the first few years, I didn't really pick up on what was going on, but I would get headaches. I'd feel irritable. I'd get muscle spasms and pains. And it took a conversation with some friends who'd been doing the fasting before. And they said, well, this is about caffeine, actually. So you're right. Caffeine is a great example that I think people would be able to relate to.
So when somebody says, I don't like the idea of medication, I don't like the idea of putting something in my body that isn't supposed to be there. Or what about every time you have a cup of coffee, every time you have a cup of tea or a drag on your e-cig? You're putting something in your body that evolution hasn't suggested you're supposed to put inside you. It's the same, isn't it, really?
It is. And, processed food as well. That's not what we were designed, if you like, to deal with. But our body handles medicines in just the same way it handles anything that we smoke, drink, eat. Your liver, your kidneys, they're going to work to identify anything that you've taken in that could be potentially harmful, that it wants to get rid of. And then, your body's going to metabolize that, break it down into a version that it can be expelled. So whether it's food or a drink or a medicine, whatever you smoke, your body's doing the same kind of things with it. It's metabolizing it and breaking it down. It's your body's way of keeping you safe.
So coming off antidepressants, how would somebody know that it's the right time to start reducing? Would they have to go back to their GP?
Yeah, I think that's, for me, that's a deeply personal decision. And it is something that I work with a lot of people on. I help a lot of people to come off of antidepressants and other medicines that in some cases they've taken for 20 years or more. And what I've learned by working with people on this is each individual experiences it differently. It's something that you need to do with time. So just stopping taking a medicine generally isn't the best approach. You need to wean the dose down over time. Often people will need quite a lot of psychological support to get through the process and someone to talk to about what they're experiencing. Because people, when they reduce their medication or stop the medication, will experience a range of things. So they often need someone just to talk through what they're experiencing. And sometimes my job is just to reassure them, okay, in 3 or 4 days, this is going to settle and you'll be fine. And sometimes it's about me helping them to identify, is this a side effect of kind of coming off the medication, if you like, or is this a sign that an underlying health problem is starting to come back into the picture, and teasing out what's happening here and what are we going to do about it, working together. So my job is always to help people walk side by side with them through these processes at the pace that they're comfortable with.
I guess things have been difficult for the last 9 months, and maybe will be for another 9. But if somebody needs to change their medication in some way or change their dose because one of the things we find as a therapist, sometimes people come to me just because they want to learn how to lose weight. It could be that simple, and they're on diabetic medication. And one of the things we look at is go, right, you're quite overweight, but if you start losing weight, then your body is going to be changing, and you need to regularly speak to your GP about changing the dose of your insulin or whatever. Do we find the same thing with antidepressants, that if somebody's body changes in some way, that their dose needs to change?
Not as much, no. I mean, there are some occasions where we need to be really careful. So if someone's kidney function changes significantly, so as we get older, our kidneys don't work as well, but sometimes people have a steeper decline in their kidney function for some reason, then that can mean that medicines accumulate and doses might need to be adjusted. Sometimes what we observe as people get older is that they start to have more and more side effects on the same dose. So we just need to ease back the dose a little bit, and that's good practice. So it's good practice to keep any medicine's use under review, and that's a big part of my role. And I just want to highlight, I suppose, one particular issue around medicines, particularly lithium, olanzapine and clozapine, so some antipsychotics, and lithium, a mood stabilizer. A lot of people don't know, but if you smoke, then your body gets really good at metabolizing those medicines and getting rid of them, to the extent that if you stop smoking, the amount of clozapine in your body or olanzapine in your body can double with the same dose, which can lead to problems. So it's really important, if you change your smoking status, if you stop smoking, or also if you start smoking, it's really important to talk to a healthcare professional about your medication, because you might need a dose adjustment to keep you safe.
You used the word holistic at some point, maybe it was before we started recording, to look at everything as a whole. And you really highlight there the importance of being an individual, of being unique, and of the practitioners that we seeing each patient as specific and unique and individual. And we can't just put everybody in boxes and go, well, you have this disorder, so this is the medication you must take. Everybody's life, everybody's brain is differently, from gender even. I mean, if you look at a lot of the research with the, I guess it must have been, if I'm looking at psychology research, it must have been about antidepressants and similar stuff and mood stabilizers. But some of the original, a lot of the studies, when they're done with university students who they're taking part in some trial or something for extra credit or something, I don't know. But it's always the same demographic. And that's not how the world works. We don't have all the one demographic of 22-year-old men who just want to cheat the system in some way and get extra credit. And everybody's brain is different. Do we see differences that women might have to take one medication but men have to take another, or is it just individually everybody's different?
I think it's right to say that individually everyone is different. There are some key differences between men and women that we need to think about with some medicines. Age can be important. How well your liver, your kidneys working, whether you have any other health problems, any other medicines that you take, and the particular nature of the way that you're feeling. So some people with depression will feel very slow. They feel like they can't do anything. They've got no energy. Whereas some people are full of energy and really, feel anxious and irritable. So that can inform what medicine you might choose to go for. And it's the same with other conditions like, anxiety, psychosis, bipolar disorder. I prefer just to think of everyone as an individual, because actually, if you think about that long list of different factors that I need to consider in choosing the best medicine, virtually no one is going to be the same as anyone else that I ever see in clinic. They're all on different medicines. They have different health problems running alongside their mental health problem. So it is truly about a holistic assessment of each person as an individual.
Are there any myths or misconceptions that people bring into you sometimes? Any concerns that are really totally unfounded?
Oh, well, I think, the really good one that we touched on earlier was around medicines being addictive and worries about that. We talked a little bit about that. I think that there are just from listening to people talk and from talking to other colleagues, some really interesting learning has come out. So at this point, I want to credit a colleague of mine that works in Sussex Partnership NHS Trust called Nana Tomova. She's on the verge of publishing some qualitative research about what people think about their medicines, what role medicines play in their life. She spoke to people with psychosis specifically about this. And she got some really interesting findings. I'm not going to talk about all of them, but for me, one of her findings in particular chimes with what a lot of people talk to me about with respect to medicines, and it's about what medicines mean to people. So one of my jobs is helping people to find the right medicine for them or the right approach, whether that's a talking therapy or something else. So much of the research tends to view people as being a problem. So we talk about, why people don't comply with their medication, why they don't take it, why people don't engage with services, and we describe people as, not engaging. And there's a real dilemma in that for me, because I actually think all that means is if someone doesn't engage with the service, well, maybe we're just not offering them something that they want right now, or we haven't found a really good way to connect with them yet. So I think we should take responsibility for that as healthcare professionals and try and work with people. If someone's not taking their medication, perhaps we really need to reflect on how it started. Were they given good quality information about it? Were they involved in the decision? Have they found it useful? Has anyone talked to them about side effects? What's the reason why they're not taking it? So one of the myths for me is that people are they don't comply with their medication. They don't engage with treatment. I think that's not the case. I think that's just shorthand for we need to work harder to try and find the way to work with people and unlock those things.
Do you think there's a lack of trust?
I think there can be. And again, one of the things I've observed from working with people is often the most important conversations don't happen in that first appointment. It can be the second or third appointment before some of the really important stuff starts to come out. And then we start to have the conversations we need to have. So I think trust is incredibly important, and it makes sense. I mean, just from my own experience, if I go to see my GP about a matter, how comfortable I'm going to be talking to someone that I don't know from Adam about something even as straightforward as a fungal nail. I feel embarrassed. I'm uncomfortable. I imagine how much more difficult that would be if I was going to start to talk about, incredibly personal experiences of mental health problems. That must be such a difficult thing to talk about. So I think it's actually one of the big privileges and honors of my job to get to talk to people about these intensely personal experiences and to be able to work with them to try and find a way to get them to move towards the goals, whatever those might be. But often they're not what I think that they are.
Because your thoughts about their goals when they first come in are different to what they eventually bring to you 3 sessions later.
Yes, that, but also I think, again, so much of the literature and so much of mental health practice is about risk and it's about symptoms. I don't find that people are all that interested in talking about voices. They're not all that interested in talking about things like that. What they really want to talk about is being able to go to work, living in a good place, having a fridge that works, being able to have a good relationship with family and loved ones, friends. Those are the things that are really important to people. And one of the things that Nana from Sussex found in her research was that we need to think more about medicines as a tool to help people work towards their goals rather than medicines as a kind of be all and end all. They're a means to an end to help someone to get towards where they want to get to. Another thing that she found was for some people, when they reflected on their journey, it wasn't having an episode of psychosis that was important. It wasn't the diagnosis of psychosis that was important. What became important was the day that they had to start taking medication for the psychosis, because actually then what they did was intrinsically link taking medication with being ill. And one of the things we talk about a lot in mental health is, getting people well, keeping them well, recovery. So for a whole bunch of people out there, what they'll be thinking is, well, how can I ever recover? How could I ever be well if I need to keep taking this medicine? So I think that really opens up some really interesting dilemmas for us, and probably some really important conversations that we'll need to be having to work through those dilemmas.
Yeah. There's a mindset there. Like you said, there's a link, there's an association that says, I am taking this medication because I am ill.
Yeah.
And therefore I'm always ill.
Yeah.
But if somebody isn't fit and they want to run, they want to jog because they want to be fit, they then want to stay fit by carrying on jogging. But we have a completely different attitude towards exercise and medication.
Yeah. So it comes back to that stigma, I guess, that you talked about, that idea that we have about medicines. Perhaps that's one of the things at the root of it.
Yeah, we don't have a stigma about, I need to make sure I get all of my 5 a day fruit and veg. Maybe some people do. Maybe some people look at the fruit bowl and go, the only reason that fruit is there is because I don't have enough of it, and that's why it's in the house. Therefore, as long as that fruit is always there, I'm always going to be ill. But it makes no sense. It's absolutely ridiculous. So you were talking about voices, psychotic episodes, and schizophrenia, which is, although as a talk therapist, I don't see so much of. It's psychologists that tend to deal with that. So I don't tend to see too much of it, or I do. Sometimes I help mop up some pieces afterwards when somebody's had a diagnosis and they go, I need to learn to live with my schizophrenia and I need some assistance with that. I guess your world is a little filtered because almost everybody you see has got some sort of mental health issue, where I'm in a similar position. But how common, how prevalent is something like schizophrenia?
It's a good question. So I think the statistics vary, but it's between 0.5 and 1% of the population. So between 1 in 100 and 1 in 200 people will have an experience of psychosis. But one of the things that's really interesting to me is that there is also some evidence to suggest that it could be that around 1 in 10 people hear voices. So there's clearly a lot of people that hear voices but don't have psychosis.
I know 10 people.
Sure. So
one of them hears voices.
Okay. So that suggests that that, like so many other mental health conditions, that there are a range of different types of psychosis experience, and actually the way that they need to be treated and managed might be different. And I'm aware that my view of the world is often coloured by the fact that a lot of the people that I work with have got quite severe, long-standing treatment-resistant types of psychosis and bipolar disorder and depression. So, I don't see the same kind of people that you see, and I don't see the things that you see. And probably what we both see isn't representative of what a GP sees either.
I met you when you invited me to keynote at a conference a few years ago. And I stayed all day. I didn't just hang around for my own presentation and then disappear off. I hung around to listen to everybody else's presentations too. And one of them was about schizophrenia and how sometimes even culture and society has a part to play in the tipping point, that being ostracized, being rejected, being bullied can tip people over the edge, that maybe they were never going to show any psychotic tendencies and traits and have these psychotic episodes, but because they were in a marginalized society, that it properly tips them over the edge, and we're seeing more and more and more of that.
Yeah, so there is a phenomenon with migrant populations in particular, and I think you're right, it's because of the traumatic experiences that they might have had along that migration journey that they are more likely to experience psychosis. It isn't the strongest, most compelling evidence, but it is something I'm aware of. But also, I think it's important to note culturally differences that can appear between people's experience of mental health problems, and some languages have no word for depression. So how do you have a conversation about it? Some things are very taboo in some backgrounds and not in others. And actually, even down to the way that people experience psychosis can be different. And the way that people will accept a conversation about their medication can be different. So in general, although this is a generalization, people in the West are reasonably comfortable with a conversation that a mental health problem, it could be due to an imbalance in neurochemicals in the brain, and therefore a medicine would sort that out in the same way that insulin would for your diabetes. But actually, that conversation might be very, very poorly received from someone with a completely different background. So in some cultures, people will believe in religious phenomena, possession. Lots of people will talk about jinns and curses. So actually, they're probably not going to have a conversation with you around kind of chemistry and neurotransmitters, and you have to find another way, which is why so much of my conversation with people is, it's not about the kind of chemistry side and how medicines work. It's about their life, their ability to work, life at home, their relationship with friends, loved ones, and we'll explore what the medicines do to that. And often that gives you an opportunity to have a really good dialogue. So, for example, I work with someone, and I'm not breaking any confidentiality here, but he works a job. He takes medication for psychosis. When he reduces his dose, he's not as able to concentrate on his work. So he struggles to do his work. But when he increases his dose, his concentration is better. He doesn't believe he has psychosis. So we don't talk about voices and we don't talk about psychosis. I ask him how he's been getting on. Has he been able to concentrate on his work? And we both understand what that means. And it's a way that we can relate over an issue.
When somebody starts taking medication, even antidepressants, is it expected that they speak to their boss to let them know, hey, this is what I've started doing, there might be some side effects?
Yeah, it's a good question. I don't think there's an expectation. In some lines of work, you might have a professional code of conduct that requires you to be really transparent about medication that you take or other substances that you might use. And you can imagine that might be for professional reasons. So if you work in the health service, you might need to do that. If you drive or operate a vehicle or a heavy machinery, then you might be required to do that for safety reasons. But actually, I think I'd always encourage people, if they feel comfortable to be open with their employer about health problems that they have, medicines that they take. Just because if there ever are any issues later downstream, then it means that it's easier to then have that conversation. But obviously then that person having that conversation could be met with all sorts of questions about, so what does it mean that you have depression? And people will bring their own unique frame of reference into that conversation. So, we know about mental health stigma, and it's something that, I've really applaud you in your efforts to defeat it, but it's still prevalent out there. So having a conversation with your employer about having a mental health problem does mean that you might have to deal with some stigmatizing views. Maybe they'll think, well, you have depression. Does that mean that you're going to be crying? Does it mean that you will take a lot of time off work? I think the only way that we get improvement and we get change is by dialogue and having conversations, though. So I think we have to try and do it if we can.
Well, if 1 in 10, according to some studies, hear voices from time to time, even if they don't necessarily think of themselves as losing touch of reality. And that's actually worth quickly mentioning here. I work with neuroses more than psychosis, obviously, as a talk therapist. The people come to me, they know that the way they think and feel is wrong. They shouldn't think and feel the way that they're thinking and feeling. So that's neuroses. And to me, that's how I sort of define the difference between psychosis and neuroses. Neurosis is when I know I shouldn't feel this way, whereas psychosis, well, no, I should feel this way. I should feel anxious because people are out to get me, for example, is the common story.
Sure.
But is it that simple that is the difference?
Now we're definitely moving into territory that's not my home ground. So I suppose I don't view things in that same way with neurosis and psychosis. And often I work with people that have perhaps both. So a lot of the people that I work with may have complex mental health problems with many different facets. that there may be, aspects of their personality that have been altered by life-changing experiences and trauma. They may also have, severe depression, or they might also have a treatment refractory mental health problem. Could be psychosis, could be depression, could be bipolar disorder. So I have to roll with each individual, and I have to try and establish a rapport with them and think about the most productive therapeutic way I can work with them. If I'm not the man, then I have to find the best way to hand them on to the right person.
Yeah, I hear a lot of people come to therapy sometimes and they're frustrated that they've been what they think is just passed from pillar to post, from one person to the next, just passed on and passed on to somebody else without realizing that they're not being rejected each time. They're being thought about and listened to more and more and more to work out, let's figure out what you need. But wrongly, they think, well, I'm just being rejected by everybody that I see. They're just going, oh, I can't help you. I'll pass you on to somebody else. And that's not the case. At least I don't think that's the case. It doesn't seem to be the case.
I agree. I think it's important to find out what's going to be the most therapeutic way forwards for someone, and then get the right person to take that forwards. I think the NHS has got a lot to learn in terms of how to manage those transitions from person to person. I think a lot of our referral processes in the NHS leave a lot to be desired. It takes a long time. People often fall between different services that exist and end up with nothing. And, in terms of the emotional intelligence of that process, it's not great. But I think it's something that a lot of areas are working on. So, for example, I know work has happened in Somerset, which is where I'm originally from, around community mental health services to really make them work a lot better for people. So it doesn't matter where they arrive, what part of the system they arrive in, they get the right assessment, they get passed to the right place without referrals. It's a warm transfer. It happens seamlessly. So there isn't a wrong place to arrive, but you'll find your way to the right place. And I think, that example is one that a lot of different parts of the country are probably looking to be following over the coming year or two in terms of how that works for people. So I think in terms of the experience that people have of mental health services, it can be difficult, it can be frustrating. People feel like they're on a conveyor belt. They feel like they have to tell their story over and over and over to so many different people, which I can see is, from the way you've reacted, is something you can relate to.
Yeah, I hear my clients' frustrations a lot, that they're having to go to another specialist and they're telling, like you say, the same story. They have to start at the beginning and go all the way through it, and it's tiresome. It really is, and it's a shame that for now, it is what it is. We just have to accept that. So if somebody thinks that they can maybe do with more than just talk therapy, and they need a bit of extra helping hand, or maybe they're one of those 1 in 10 who they're hearing voices, but it's not so serious that they think they're going crazy. It's just, well, I have this weird experience sometimes. What should they do? Is the GP the first place to go?
Absolutely. GP is the first place to go unless it's an emergency. Have a good think before you go to your appointment about what it is that you really want. What are the questions that you really want to get your answers to? And sometimes it's good to write down your questions or your worries, so that when you get to the appointment, if all of a sudden you feel nervous, that you've got your piece of paper and you can read it out, or you can hand it over. Because I think sometimes people will get to an appointment and the cat gets the tongue. It happens to us all. So I think that can be useful. So that's something that I definitely recommend. And if you go to your first appointment and you don't manage to get what you need, I think it's about keep going back. Keep trying to get the answers that you're seeking. And sometimes people will need to be referred on to a specialist service like the ones that I work in for more of an assessment and more kind of different treatment options. I'd encourage people, don't suffer and struggle with mental health problems. Get out there. There's help out there. So kind of go out and grab the help that you need so that you can move on and live a more comfortable, happier life, really. And sometimes that will involve medication. Sometimes it won't.
Are there times then that somebody will go to a GP assuming, well, I clearly have depression, I'm crying all the time, he's just going to give me some pills, and the GP maybe won't?
Yeah, I think that will probably be a common experience for people, and sometimes that will be the right decision, and sometimes it won't. It's not always easy and straightforward to make that assessment the first time round. Before we finish, I want to get in a plug for something, if that's all right.
Absolutely. Plug away.
Okay. So one of the most common things that people ask me is where can they get information about medication? So, we all know that from time to time, your daily newspaper will publish an article about antidepressants and how they don't work, or this medicine and how it does this, how it does that.
Clickbait.
Yes, particularly when it comes to medication for mental health conditions. Most areas of the country have, in their mental health trust, will have access to a website called Choice and Medication. So if you just Google Choice and Medication and the name of your local mental health provider trust, whatever that is, most sites are public facing. You'd be able to access medication leaflets there that are really good for people because they're not written in jargon, that they're written by pharmacists. They go through groups of members of the public so that they're written in the right language for people to understand. They break down the issues into small kind of bite-sized chunks. There are also kind of more visual formats for people that need something more pictorial, rather, if people struggle with reading, for example. So that's a good place to go and get some information leaflets if you want to get some information about the treatment that you're considering or that you're already taking. And I think when it comes to information out there on the net, you've got to be careful. There's an awful lot of information out there, and it's about interpreting it with care. What I would always say to people is, if you read something and you're thinking about changing your medication, if you're thinking about doubling your dose or stopping your medication because of something you've read, have a conversation with a healthcare professional about that first. What I always find is that conversation, often we're able to put the medication use into context. And sometimes just that conversation unlocks new information and learning, and then you can kind of formulate a plan between you on what to do next. So I think I always advise people, don't rush in and make changes with your medication. Have a conversation with someone and just kind of make sure that to come up with a plan between you on what to do next.
Wonderful. Thanks very much for sharing that. I guess because every area is going to have a different website to find a lot of that information. I can't put anything in the show notes about that. They're just going to have to leave it to the search engine to find that information out, I guess.
Yeah, Choice and Medication. It's pretty ubiquitous now across the UK, and most people will be able to access it through the public-facing internet site of the local mental health trust. So if you can Google local mental health trust, find their website, and then search Choice and Medication, then you can probably find it. Now, I don't work for the company that make those leaflets. I don't have any vested interests, but it's a really good resource, and it's so commonly requested that I can't leave the show without mentioning it.
Excellent. Well, if we can do anything to spread the word, like I always say in my podcast, I'm here to help inspire and educate. If there's something that somebody can learn, then we're going to make the world a better place. We really, really will. Matt, thank you ever so much for coming on to the show. It's been lovely to chat with you about all of this, because I don't tend to get involved in the medication side of things at all. Very rarely will I liaise with even my own clients, GPs or psychiatrists, because it's not my place to do that unless they want me to. Occasionally I have no choice, but it's very, very rare. So this is a real learning curve for me, let alone for my listeners as well. So Matt, thank you ever so much for coming on board.
It's an absolute pleasure. Thanks for having me.
And there we go. There were a few things that really jumped out at me in that chat. One was the brilliant Choice and Medication resource. I googled Choice and Medication Warwickshire just because, well, that's where I live, and it linked me to their full site, absolutely chock full of fact sheets and leaflets about different antidepressants and conditions and issues and problems. And I can see why Matt was eager to spread the word, because they're a really good resource. So do check that out if you need to. Another thing in our chat that jumped out was that oddity that placebos work so surprisingly well for mental health issues, better than placebos do for other problems. Not as well as genuine antidepressants, but surprisingly well still, all things considered. But actually, I guess it shouldn't be that surprising, should it? Because like Matt said, part of the treatment, whether it's with antidepressants or the placebo, is going to be sitting with a professional and talking about how you feel. And if that's all it takes to get the ball rolling, then whether that's with a professional, a friend, somebody on the end of a telephone helpline or just a Twitter thread conversation, then it's definitely worth doing. And if you combine that with the right medication for you, then hopefully you or those that need the help will get it. So, keep your spaces, wash your faces, and I'll be back before you know it. See you soon!